we were just talking about that. You know, everybody's so rushed around here. Maybe y'all were appreciating this time to just sit quietly. Okay, we'll interrupt it now. We're operating without a quorum. We've got 3 members here, and we generally operate as soon as we have 4 on this in the subcommittee. We do have a couple of bills that we're going to hear today. Our format this year will be that rather than saving all of the bills coming in front of the committee, we'll try to address as they're referred to us. Particularly, we have a couple of fairly simple ones today that we will be hoping to discharge to the full committee. We have, basically our agenda is to take up those 2 bills, which we will wait till we have a quorum here to do that. And we do have our acting state health commissioner, Dr. Colin Green, with us here today, who's going to make a presentation to us, introductions and what have you. And Dr. Green comes, Senator Vogel, from your neck of the woods, through the health district area up there. And so we're very pleased to have you here today. And then Mike will be giving us a staff overview of the HHR budget and amendments there too for 29 and 30. And we should have some way when we're in a moment like this of taking advantage of all the knowledge that's in this room, because we need to have a lot of different conversations over the next couple of weeks. And a lot of y'all that we need to have those conversations with are right here, right now. So we could almost just go around the room and start talking about things. But we won't do that, though. We will.
Why not? We can fix it right now.
we could do that. Dr. Green, I'll call on you first. If you could come and share with us. Yes, come right ahead. We're pleased to have you with us here today.
All right, thank you. So, Madam Chairman, Mr. Ranking Member, and Senator Vogel from Winchester. So first, I just want to say it's my honor and privilege to be allowed to lead the Virginia Department of Health, to pick up from my humble district in the northwest corner of the state and come down here to Richmond to be the acting commissioner. During my 4.5 years as a district health director, I've been and I continue to be impressed with the quality and dedication of Virginia Department of Health personnel before you in this room, and the importance of our mission, especially during the last 2 years, which have been challenging to say the least, and look forward to many other successes for the future. Let me see if I can work this. Here we go. So I'll present you today our budget priorities for the next biennium. And you know as well as I do, having timely and predictive resources are absolutely necessary for strengthening the public health system, and also they demonstrate an investment in Virginia's readiness in the future. So our mission has been the same for a while. We stand by it and we're proud of it. We protect the health, we promote the well-being of all persons in Virginia. And our goal is that Virginia will be the healthiest state in the nation. Depends whose measurement you look at. Last I looked, somewhere between 15th and 19th. So we're kind of Lake Wobegon. We're above average. But yeah, but we're not where we want to be. We'll work on it. Now, I will tell you, if you look at case rates and death rates for COVID, we're, I think, number 12 lowest for death rates, and case rates were in the top 10 for lowest, or bottom 10, which is where you want to be there. So Virginia is actually a leader there, and the states that are better than us are, not to be offensive to any other states, things like Vermont and Hawaii, the kind of smaller states. So we're one of the absolute best of the medium to larger states. And there's more to VDH than COVID. Obviously, the center block there talks about COVID. If you travel along with me clockwise, you can see we support the Women, Infants, and Children program, or WIC. We certainly do a lot of health education, both at the citizen level and at the government and leadership and community leader level. We support families. We certainly are very, very strong in environmental health. That's one of the foundations of the 20th century success of public health, is keeping the food and the water safe, as evidenced by the picture of the bay, and a little ironic recently, given the sewage spill that we had in a creek. Had to shut down oystering for a while in one spot. And then we take care of rabies awareness. We want to make sure people understand how to avoid rabies and to take care of all creatures great and small right there. So how do we strengthen public health? Well, we want to improve our readiness. We want to be more holistic and integrated, so we want to be more intertwined and working along with the community and the community leaders. And then we have some legacy systems that really could use some modernizing and innovating, and I'll talk about those in a little bit too. So the first thing, and first I want to thank the General Assembly for your vision in appropriating American Rescue Plan Act funds to facilitate many things in the health department, increase productivity, leverage technology, and certainly help us in the fight against COVID-19. So I won't spend a whole lot of time talking about specific programs, but suffice it to say, in my office in Winchester, my computer works on a T1 line, which is the same technology the U.S. Army had in Bosnia in the 1990s, so it's 25-year-old technology. And when I get on a Zoom meeting, everybody else's computer turns into a glacier in the entire office. So that's what we're dealing with now. Facilities broadband will be a great blessing. In 2004-2005, the Department of Defense made its final transition from paper to electronic health record. Virginia Department of Health has yet to do that. Every other private practice in the country just about has an electronic health record right now, and we're looking to follow suit.
Yeah, I was on a study group about 15 years ago dealing with that, and how urgent it was that we have a program like
Right.
that. And here we are.
Right. And you know, the two best things about an electronic health record: one, you never lose the record; two, you can always read the doctor's handwriting. So there's right much district maintenance, various facilities that have needed upgrades, administrative systems, and again, IT service is just a part of that, and records management. So all of that is, and well beyond just health records, has been funded by ARPA funds. And again, thank you all for making sure Virginia got its share. So here's our proposed funding and staffing for the next fiscal year. To effectively perform our mission, we've got to strike a balance of capacity and capability. Our proposed budget requests include an additional 68 FTEs and then 11 temporary staff for that total of 79 you see on the left-hand side of the chart. I don't know if there's a laser on here that works, but moreover, we're requesting a modest increase of $30 million in FY23 and then another 33 in FY24 from our FY22 baseline. More than 75% of the VAEH budget right now is comprised of federal funds with, my script here says, complex eligibility. That is an understatement, to say the least. And sustainment requirements. So timely and predictable funding is essential, obviously, for our mission as for anybody else's. And I'll go through section by section the things that we're requesting. And again, I have subject matter experts here if you have questions about any of this. So our epidemiology, those are the people that actually keep track of disease for us, and they've been working double overtime during COVID. Genomic surveillance efforts are our method of actually tracking what kind of virus, what strain of virus is busy. It's how we know that we have Omicron right now, but it can be used to track all kinds of things, not just COVID-19. Genomic data analyst is responsible for ensuring we have all the proper sequencing data and that it's handled properly. And I believe this money would cover 2 FTEs plus equipment and supplies for this project. And again, it allows us to keep track of what strains of viruses are in the community. It helps us to better manage them. Without that, we would have been in a world of hurt here in COVID-19. The next one is comprehensive harm reduction, which again is designed to decrease the effects of drug use, primarily IV drug use, which can encompass the spread of a lot of other infectious diseases. The next is the increase in the next two actually are an increase in the capacity of the Office of the Chief Medical Examiner. We have struggled with the staff that we have to keep up with ordinary needs, much less the increased number of deaths that we've had with COVID-19. Local match year, 3 phase-in provides general funds to complete the phase-in of local health department match rate. In my 4 years, I think I've finally gotten used to how Virginia funds local districts with a combination of state and local funds. And the match rates, you all are all too aware, have all been standardized and readjusted from, I guess, 30 years ago when they were first laid out. And quite a few of the communities are paying less and the state's going to be paying more. So these monies are necessary to keep up with the changes in the state requirements for VDH. And the last line there is funding for the temporary assistance for needy families and funding for healthy families, which will be moved back to the Department of Social Services. It's a wash for the state government, but it's a negative for VDH because that particular program is moving away from us. So the first line provides funding for a data sharing agreement and provides 1 FTE to support the sharing of data regarding firearm violence in Virginia, and the firearm violence was specified, I believe, in a program under the previous governor. So that's why it's firearm violence and not violence in general. And then the next line provides funding to continue the Virginia Resource Mothers Program, and it supports temporary assistance for needy families funding, providing to at-risk pregnant teens and teen mothers through care coordination and visits by community health workers. The next line provides funding for marijuana prevention and education, and this is actually in preparation for the legalization of marijuana. And experience from Colorado shows that, probably no great surprise, that these programs were necessary when marijuana was legalized, and the education piece was needed before the legalization happened, which will be well before there's any tax revenue from the sale of the product. So,
Mr.
this
Co-Chair?
is front money. Sir?
May I ask a question about this?
Sure.
Sure. We have several different buckets of money for educating the public on people who should be avoiding use of marijuana or using it more responsibly, including some for the Department of Education to keep students well informed of what they should not be doing. And we have here Department of Health, and I believe there may even be others. And I was just wondering if there's any coordination among the different people who will be putting up public service messages.
If I have anything to say about it, there will be.
Okay.
This funding, I believe, is primarily for adult education rather than school, but Mr. Hicks has got, your name is on this, Bob. Anything else to add?
Just to answer Delegate Senator's question, when we get involved in health education, we normally try to collaborate with a number of different agencies, whether they're state or local or nonprofit organizations. So yes, there will be some collaboration.
Great. Thank you, Mr. Co-Chair.
And then the last line there doesn't involve any money moving around. It just changes the language for assignment of Virginia Sexual and Domestic Violence Program prevention funds. Originally, there were, I think, only 6 organizations that were eligible, and the new wording opens it up to about another 40. So increasing availability of funds and probably increasing availability of programs in various parts of the state.
Is there additional funding for these programs with this expansion?
I don't think so. Again, Bob, do you have any? Senator asked if there was any additional funding. My understanding it was not. It just increased the choices that you have.
Not in the Department of Health. So
Yeah.
the prevention fund is administered by both VDH and DSS, and on the DSS side, there's an additional $650,000 for the fund. But DSS's focus is more the domestic violence, whereas VDH focuses on the other one.
The main thing is you have 40 vendors to choose from instead of just 6 now. So I talked about environmental health earlier. Environmental health is one of the one of the most fundamental parts of public health. And again, it's, in a lot of ways, it's a difference in our life expectancy from some of the less developed countries. And if you've traveled in places like India and sub-Saharan Africa and other parts of Asia, you can see that very quickly. So we don't want to let, while we developed our environmental health programs in the early and mid 20th century, we don't want to let our guard down and let them fade. So the first line is funding 7 FTEs, again, plus supplies and equipment, to establish, operate, and develop a pilot that would provide oversight of the septic tank pump out and inspection programs, the Eastern Shore, Middle Peninsula, Northern Neck. So all that area that was on that picture I showed you of the bay before, same area that we had the sewage spill in just a few days ago. Extra money to actually operate a program, which, if I'm not mistaken, there's also a bill in the legislature to actually give VDH the authority to run that program. This would provide the money to operate it. The next one restores unallotted funding for a division of shellfish safety, and that applies 2 FTEs, again, for increased demand of services. Next line provides funding for assessing shellfish contamination in rural growing and harvesting grounds. And the one below that is not related to shellfish, but it's near and dear to my heart, from Winchester. Provides funding and positions to support the Grade A milk program. We had a very experienced milk technician retire and had to do a lot of scrambling to try and replace him. And Winchester had to piece it together with parts of 3 different employees for the time being. So this is a crucial piece, since the Hood Milk Plant in Winchester, I think, is maybe the largest on the East Coast. Is that right, Bob? It's enormous. It is amazing the size of the facility and the amount of milk it provides. So the next under medical facilities and our licensure and certification, our first line provides funding for a hospital plan and reporting requirements, 3 FTEs of people to keep track of these new requirements, and it addresses a new legislative mandate that requires hospitals that we license to submit an approval plan for services provided to survivors of sexual assault. Next line provides funding and positions for an increase in regulatory caseloads. That's 1 FTE, again, plus the necessary supplies, and funding to respond to increased regulatory caseload in the Office of Licensure and Certification. So before I talk about monies going to the Office of Drinking Water, I'm sure everybody's aware of the staffing challenges that VDH had there in the last year. I got here and got the story of what had happened, and before I knew that the governor had recommended an amendment proffering some money toward the solution, the short-term solution of that, I listened to the problem, and I directed my staff to come back with courses of action for me, with the requirement, the non-negotiable requirement is that the drinking water remains safe. So it'd be easy to solve the money problem. You just unload however many people, balance the budget, we're done. But what's the drinking water look like after that? So that's the wrong way to look at it. So we're going to start with safe drinking water, and then come up with courses of action to supply those people that we need to make that happen. So on the table, however, and these are unrelated. The first line, and there should only be one 482,000 on there.
It's because it starts in 22.
Oh, is that it? Okay, so it's each year. All right. So it restores unallotted funding for state match for something called the Drinking Water State Revolving Fund. It increases the general fund appropriation, and it draws down money from the EPA. And a lot of these things I'm going to talk about are involved with that drawdown concept. Second line restores unallotted funding to replace the ODW database, and VDH has to update that database to meet state security standards and federal reporting requirements. The next line provides for the implementation of a water sampling verification program, and that requires 7 FTEs, and funding for program implementation to validate and verify water quality and conditions. Next line addresses equitable access to drinking water, to provide support and to consolidate small waterworks, to reduce health violations, improve the economies of scale, and address resilience and reliability at small and disadvantaged systems. And again, in my old district in the Shenandoah Valley, we had lots of those little private water systems, and they frequently had problems. And the last line is regulatory governance of ARPA funding, 11 temporary staff for the next 2 fiscal years with requisite expertise to manage the increase in drinking water construction projects. So the first line for rural health provides matching funds for the state loan repayment program, federal grant, and provides funding to match the SLRP federal match. So again, we're drawing down money, would allow VH to draw down a total of $1.5 million in federal funds. So we're getting better than a 1-to-1 match on that deal. And then the second line provides matching funds for the Virginia State Office of Rural Health federal grant. Again, provides funding to maximize the full federal drawdown of $230,000. Ratio is not quite so attractive on that money, but it's still probably a 30 to 50% return on each dollar we lay out. And federal policy requires a state match, 3 times the federal award, so we get $1.33 for every dollar we lay out. So for mission operation support, several categories here. First line provides funding for data software licensing requirements, maintenance and enhancement of data management systems, and it supports development of accurate and timely public health data. Without data, we have a hard time functioning, and that has become particularly evident during the COVID outbreak. You have to have not only good data on things like counting disease cases, but on the effects of the mitigations, for example, we put in place. So the more data we have that's meaningful, the better decisions we can make and the better recommendations we can make. Second line provides funding to support information technology portfolio, 2 FTEs in funding to support an increase in IT projects. The third is to support additional funding and positions for the Office of Internal Audit. Again, understaffed, struggling to keep up with the audit requirements. 2 FTEs in funding to respond to the increase in investigative workload. Fourth bullet there is to provide funding for admin costs associated with the Opioid Abatement Authority, 2 FTEs in funding to support administrative functions in response to a new legislative mandate. And then the last line is funding for an integrated e-referral system. So the concept there is to contract for that system in order to provide a more holistic public-private partnership, facilitate timely patient referrals, patients to public health and social services. So the concept there is somebody comes into the health department for problem X, and we find out that they're struggling to find a place to live, or they have nowhere to live. They need a job, and that's why they have nowhere to live, and they need some care for their children. And through this system, we could electronically make referrals to the agencies in the area to take care of that one particular person. Some funding for VDA budget amendments. So first line provides funding for Virginia Health Workforce Development Authority, and it establishes a work group to conduct a study on addressing primary care workforce issues and potential solutions. Second line is additional funding for the Special Olympics Health Athletes Program, and that's, as it mentions, a lot of these things are pass-throughs. Third line is budget support for the Childhood Cancer Foundation. Last line is support for pediatric hospice and palliative care program, something we don't like to think about too much, but for families that are in that sort of situation is crucial. So takeaways, again, we've been very busy with pandemic response for COVID-19. We're not done with it, unfortunately. 2 years out, we're still not done with it. Requires continued vigilance. It requires timely and predictable resources, as discussed earlier. We require innovation, agility, and strategic partnerships. And we require that so we can continue to, even after COVID, continue to protect the health and promote the well-being of all people in Virginia. And investment in public health is vital to ensuring our chances of Virginia becoming the healthiest state in the nation. And with that, we can answer any questions you may have.
Okay. Any members have additional questions
Senator,
at this time?
Senator Evans, Senator McClellan, I'm sorry to have had my back to you for the whole time.
The, here, a couple of questions or just things to talk about. Your, one of your earlier bullet points, enhancing genomic surveillance efforts.
Yes, sir.
Our committee, we had a retreat in Roanoke, the Finance Committee did, and we toured the Fralin Research Center, and there was a lot of work going on there with data, creating data for you all, I suppose. How is that handled? What's the interface with them?
I'm going to look at Dr. Peak, who's my expert there.
So, both our local health department and at the state level, through working with DCLS, we work closely to collect that data, and a lot of that information comes through DCLS and then is reported to us, and we keep that updated on our website so that we can track the variance.
Okay, yeah.
This is specifically for people to help analyze and follow up on that data, which we don't have in
Okay.
place
So
now.
it looked like they were doing advanced work there in identifying trends with the COVID and things of that sort, and I guess that was feeding into your system, so you know the next steps, what have you.
Yes,
Yeah.
so, so labs from around the state do report to DCLS, and we incorporate all of that data into our data tracking, so we know which variants are circulating in Virginia.
Okay, thank you. The other question, just in general, you indicated that you know, a number of additional FTEs, first year and the second year. You also observed as you were beginning that 77% of your funding comes from feds, so it's not general fund as opposed to the state fund.
Right.
Because I was seeing there was a lot of those positions that we're adding were coming strictly from general funds, it appeared. And then you had one example like the Resource Mothers Program, which apparently the federal stream is being pulled back, and so we're picking it up from general funds.
Right.
Is that the general trend you're seeing now, or where? In other words, I was seeing as you went through most of the FTEs, newly created FTEs, it appeared were coming through with just general fund dollars.
Yes, sir. For the most part, that's true. The federal funds, a lot of the federal funds we got were COVID related. Not all of them. I mean, we've had the WIC program for a long time. We get money to maintain our local health emergency coordinators. Those are all federal streams. But, I mean, it is not an unusual trend for the feds to say, hey, here's $5 million for this great program.
Right.
And then, oh yeah, that'll only last you 3 years. You're on your own after that. Even when I was on active duty, the federal government would come and say, here's $1 million, we're going to buy you a new CT scanner at the hospital. And we're great. No maintenance program attached to that. That had to
Okay,
come out of our hide.
gotcha.
I mean, that's kind of the way it works sometimes.
Right. Well, that's something we generally have to be aware of. You know, there's federal money to get a program up and started, and then we become dependent on it. We really like
Yes,
it.
sir.
And then, a couple years later, the federal funding goes away, and then we have to supplement it then with the general funding.
Yes, sir.
That was just okay. And then the last question I had observed was your e-referral system, which had like an $8 million price tag.
Right.
Is that part of a comprehensive statewide effort, or do you have partners with that as far as where the referrals will be going to? Or has that been hammered out?
There is a program in place that we've started with, but it's not necessarily endpoint, and I forget who's my SME on that program. Okay, Jeff. Jeff's
So-
over, Chief of Staff.
Yeah, so currently, we have a contract with a group called Unite Us. So there's a program here called Unite Virginia. So there was money that went into that initially. We have a contract with them that runs through June of this year. And then any additional funds potentially that could come about would be a separate RFP that would be competed in starting in July. So Unite Us, it is an e-referral system. It's in place currently with, I don't know the exact number, I want to think about 1,500 entities across the state. And that could be nonprofits, it's agencies, local health departments, DSS is getting involved, a lot of state agencies and a lot of nonprofits, so that when people are at one place for a service, if it's noticed that they need to use additional services, that system is used to link them to these other entities, get them the care that they need more quickly.
thank you. Senator Howe?
And so if I'm understanding, not only nonprofits and other non-governmental agencies can use this, but other state agencies can use
That's
it?
correct,
But you're
yes.
paying for the whole thing out of your budget?
That's correct.
Other questions from the members? Okay.
Did I need to show the appendix slides too? Or is that just reference? Okay, that's what I
Yeah,
thought.
we'll look at that.
Yeah.
We'll get Mike to read all that and share it.
All right.
Explain it to us.
Yeah, exactly. Right. Well, Dr. Green, thank you so much, and your
My
staff,
pleasure.
all of y'all that are here today. We really appreciate the work that y'all do. I know it's been tough over the last couple of years.
It's been a challenge.
Yeah.
But it's been
yeah,
rewarding
so,
as well.
Yes, and I think it's been exemplary, really. I think as far as state efforts, I think we've been doing extremely well, considering what's been going on out there in the world.
Virginia's been a leader.
Yeah, yeah. So thank you again, Dr. Green, for being here, and the rest of you all who came. We really appreciate it.
Your
Look forward
tax
to
dollars
working.
at work, Senator.
Okay.
All right.
All right, thank you, thank you. All right, I saw Senator Mason in the room. I think we'll come back to a couple bills that we had on our docket.
Sir.
And I'll also use this moment to point out that we're in modest accommodations here in this room, and we don't have Zoom capabilities. For those of you stakeholders, that get used to the Zoom capabilities in other rooms, we don't have those here, so you'll have to show up as long as we're meeting in this very modest room.
Yes, sir, Mr. Chairman.
All right, then a motion.
Senate Bill 307, Mr. Chairman. I'm sorry to trouble you with this one, but this was brought my way because it turned out that we have done everything we can over the last few years to really push kinship care. We came up with some money that I came and asked the big committee for to keep that program rolling. So there have been a handful of cases where a kinship situation was denied. And so some have gone to lawyers and said, hey, I think I was improperly denied. I really want the kid, whatever it may be. Turns out there's no appeal process. So what we have done here is set up an opportunity to appeal lines 21 to 25. If it's denied, you can appeal from the local board's decision. I talked to some of my social services folks about them. One of them said she has a situation right now she thinks they would appeal. And she said, that's not a bad thing to me. I think I've made the right call, but this will be a second set of eyes. And so I think it's a great opportunity. Well, along with that, of course, comes dun, dun, dun. How many cases could we have across Virginia next year? And I guess you never miss a chance to pick up an FTE or two, Mr. Chair, Madam Chair. And so we from the start, went to social services to ask for a number. We're going to use the same appellate process that they use for CPS cases. So there is a structure in place. They ask for one more evaluator to review the appeal and an administrative assistant to go along with it. That comes up to a number, it's like 180 or something. So I ask for that along the way. It is fair that we don't know how many cases would be appealed out of the box, but and we are increasing kinship care. So there are more cases. We've gone from like 8% to 17%, and we're still way behind. We're going to keep pushing super hard to get more. So that's what I'm trying to pull off and why I'm here in front of you, Mr. Chairman.
Okay. Thank you, Senator Mason. I think, yes, that the merits of the bill are clear. The issue is a bit of price tag that we have in front of us here. Take a look at roughly close to 96,000 first year, 86,000 second year in general fund, and then roughly 100,000 a year in non-general funds.
Oh, yeah.
Madam Chair, we haven't discussed this previously, but in this instance now for these smaller amounts, would your preference would go ahead and make a decision now about whether we're going to fund them rather than putting a clause on them?
Yeah, I'd rather not do the clause this year. So
As long as
if this committee makes a recommendation to the full committee, then we'll.
Okay, all right. What's the pleasure of the committee?
Question, Mr. Chair? Do we have a sense as to how many children this could help? I mean, I don't know the exact number in the foster care system, or you said we're at what percent now are in kinship care?
Mr. Chairman, Senator Eben, so does anybody have a number that they could throw at this thing? I'd hate to guess how many people went into kinship care last year. Do we know that number?
So right now there's approximately 5,000 children in foster care at any given time. As the senator mentioned, and I'm sorry, I'm Valerie Lee, Virginia Poverty Law Center.
And if I'm properly did that, I'm sorry.
We have been working, most states have about 30% of the foster families are relatives. Virginia has gone from 6% to around 18%, so we're slowly finding our way to the average. We're about halfway there now. What that means, I believe that the department had testified that they are not motivated to deny relatives because they're trying to get that number to grow. So hopefully, what I'm guessing is just like Senator Mason said, there'll probably be a bunch at first, and then hopefully that will really drop off as the department keeps pushing that sort of what they call kid first culture. But at first, I think the department is probably accurately saying it's going to need one more person to make sure they have the capacity. Whether that capacity will need to stay at that level or whether it can drop back down, and that.
Thank you.
Okay. Further questions? We had that. What's the pleasure of the committee?
Just a comment, because I know I'm the minority voice on kinship care, and everybody from Ann Holton to Mountie Mason has disagreed with me on this.
Okay.
Uh-oh.
And I'm used to being in the minority, and I'm often wrong when I am in the minority. But I do worry about some of these kids, because there is a reason there's in foster care, and it's also dysfunctional families that go through generations and across networks within the family. And so although I support kinship care, I do it with a lot of, let's look really closely at these families, really closely.
Sure. Interesting. Mr. Chairman Howell, that's a great point, because what we did last year, are you eligible for federal kinship care and foster care? If no, you're out. And so we eliminated that to try to prevent kids going from foster care in places other than with families. So I think it is important we look closely at them. This would actually give an extra set of eyes if someone was declined, but that might be more concerning to your point there. So
I think, as we work through this, we maybe should have a similar thing on the other side, flip side.
a review accordingly with those placed.
Right.
Fair enough. Fair enough.
I sometimes have similar thoughts, and I think it's valid. I think just for I certainly support this bill, but I think your issue there is valid.
That's a good.
I've seen, just in the system, it's hard to do because parents can't be assumed, or that relative is assumed to be responsible. I saw an instance where a father is coming out of prison, children had been in foster care, and his only actually involvement with the children had been, to be blunt, recreational opportunity with the mother, and somebody was awarded the children. So, those kinds of things have to be taken into account. I hate to be so blunt, but that's
So extend the appeal to some cases placed.
yeah.
Interesting.
Yeah. What's the pleasure of the committee?
I guess I would move to report, and while I appreciate the concern raised by the chair, I think this bill gives a certain level of transparency. If there is a very good reason that a particular family member should not be granted custody, that probably should be clearly explained. And so I think there's still an opportunity to review and make sure you are placing the child in the best place for that child's best interest, but I do think we need a little bit of transparency around why someone might have been declined. So for that reason, I would move to recommend reporting.
I'll second that.
Yeah, and to be clear, I think this is a good added dimension to the program.
Yes, sir.
I don't have, also, to be clear, I don't have a problem with this. I think we need to go farther.
Right.
I took your point. That's a great
All
point.
right, there's a motion properly supported that the bill be reported. All those in favor signify by saying aye. Aye. Any opposed? Okay, we have.
So, thank you, Mr. Chairman, members of the committee. I appreciate the time.
Very timely. Well, thank you very much, Mr. Chair and committee members. This is SB 241, and this is a bill that seeks to establish the Renal Advisory Council inside of the Commonwealth and connected to our Virginia Department of Health. This is a bill that is a supplement to a couple of other bills that we just recently passed. Well, it was one bill in particular that Senator Eben and I have now joined together, and that is to ensure our Virginians who are struggling with chronic kidney disease and issues of end-stage renal failure, dialysis, that they have the opportunity to get the support and the resources that they need. We know that living donor transplants are far more effective in helping individuals struggling with end-stage renal disease, that they are more cost-effective for the Commonwealth as well, and that they lead to better outcomes in terms of a patient's quality of life. And so to assist with the other legislation that focuses on the Living Donor Protection Act, the Renal Disease Advisory Council, it would be a committee that is established and composed of medical professionals as well as our clinics, our hospitals, our patient advocates and representatives, and their work would be to focus on ensuring that there are clear set of standards and recommendations for our public who are struggling with kidney disease, so that we clarify for our patients and their families the options for treatment, the options for effective organ donation, and that they have the full support and structure in order to be fully assisted. Right now, diabetes and kidney disease are affecting nearly 1 million Virginians, and it is particularly impacting our low-income communities who don't have full, adequate access to information in order to treat and care for their disease fully, and this would be a support effort. The fiscal impact that we've seen is about $41,000 annually, and this is to fund half a FTE inside the Virginia Department of Health to help coordinate the work of the Renal Disease Advisory Council.
Okay. It appears the cost is limited to just staffing support for the council.
Yes.
The members would not receive per diem and per expense.
Right.
And there's a reference to General Assembly members here, but I'm not seeing specifically the appointment where they would happen.
I think it forbids General Assembly members, sir. It says on line 47 that there are 18 non-legislative members and 3 ex officio members, and I don't think the ex officio members are legislators.
Just coincident with their terms of office, but we didn't anticipate to be General Assembly members.
That's correct.
Commissioner of Health and Director of Department of Medical Assistance Services. I don't know if that's the right terminology.
Okay. All right, further questions of the committee?
Just a comment. This sets up the fund, and we can pass this and not put any money in it. So I'm wondering if you got a budget amendment or something?
I did file a budget amendment, yes. And we were actually, before we got the official fiscal impact statement, we had requested $40,000 annually.
Okay, so our action today would then be, as far as would be created, and then the issue would then be whether or not we supplement the budget that's set it down after that 45.
That's correct.
Okay. All right. What's the pleasure of the committee? Is there a motion to report? Okay.
Yes, second.
All right. Motion properly supported that we report. Hearing no further discussion, all those in favor signify by saying aye. Any opposed? Okay. Recommendations report, that's all.
Thank you very much, Mr. Chair.
Thank you, Senator. All right. Well, that concludes our items of legislative discussion, and now Mike Tweedy will give us an overview of the budget 29 and 30.
Thank you, Mr. Chairman and members. So we've already done this at the full committee level, so this looks familiar. What I'm going to do is kind of go through it and really just highlight the things that I think you all will be talking about in the budget discussions. But certainly if you see an item that you want more information on, just stop me and ask. So see in slide 2, the caboose, it's pretty much a net reduction in general fund. That's mainly because of the federal funds and the decreased utilization of Medicaid that we've talked about before. There's also savings in the healthcare fund. The healthcare fund supports the state match for Medicaid, and that $132 million is primarily increased pharmacy rebates, but it's also repayments from managed care companies because they saw lower utilization as well. And if you remember the JLARC report of some years ago in managed care, the result of that was to impose profit caps on the managed care company. So this is kind of the first time that we've seen those repayments. You can see there's a variety of other things related to the state hospitals, staffing, overtime, pharmacy cost. There's the emergency kitchen at Eastern State Hospital. That's kind of new because they had a sewer pipe kind of explode, and so they had to have a temporary kitchen. It really was just kind of like accelerating the process because there's already a capital project to replace that kitchen. So they would have had to have a temporary kitchen at one point either way, but the sewer line just expedited that. You can see in the Department of Health, there's overtime cost, state match for drinking water. When you look at the Department of Behavioral Health, there was an additional $2 million for kind of in the caboose for this one crisis receiving center to continue. There's modernization of their IT systems and supervision of the sexually violent predators. They pay DOC to supervise them. And you can see a few things in social services related to the child welfare forecast, licensing divisions, and a couple Medicaid policy changes, which you'll see in the big bill as well. And I'll talk about it when I get there. So, like I said, I won't spend much time. So what you actually see when you look at the overall budget for the biennial budget for Senate Bill 30, probably after education, HHR was the second biggest area. So there's about $1.7 billion in net additional general funds added, although half of that is the Medicaid forecast. But you'll see some of the two other major items are Medicaid provider rates, which I'll spend a little bit of time on when I get to that, because I think that's going to be the big dollars that you all look at this session, not just what was put in the introduced budget, but the pressure to increase other rates. Then, of course, behavioral health, of course, is also an ongoing major investment. And this slide just summarizes slide 4, just, you know, the 4 big agencies in HHR, which is pretty typical: DMAS, behavioral health, social services, and health. I always refer to it as the big 4. That's usually what we talk about. That's where most of the money goes. But you can see that there's some additional money for some of the smaller agencies as well. So going to Medicaid provider rates on slide 5. So you see the largest one, it's almost $300 million in general funds. It's kind of a rebasing of DD waiver services. I'll talk on I have the next slide to explain that in a little bit more detail, and then we can talk about some of the issues with it. There's also $20 million to increase primary care services to 80% of the Medicare rate. And of course, I also have another slide on physician services that I'll talk about in a minute. Dental services, there's 5% of the second year. You know, this is something that we knew that was coming when we expanded to adult dental.
And Mr. Chair,
Senator Deed.
do we have any idea how much, whether this would actually entice more people to participate, more dentists?
5% of the second year, probably not. Those rates haven't been increased since the children's program was kind of put in place in 2005. So they're pretty low. The one proposal that existed before the internet was looking at like a 30% rate increase this July 1. That 30%, in addition to this, it would be an additional about 75 million general funds to do
And
that.
that would certainly entice people.
Definitely, yes.
Yeah, I think we have a member amendment on the table to.
It doesn't,
be more aggressive.
yeah. If you remember, it won't completely resolve the issue because if you remember what we, presentation that I kind of gave back in Abingdon. When you look at rural areas, their issue isn't just rates, it's just a lack of providers, which is the same thing on the healthcare side. It's just that your ratio of providers to people in the rural areas is just much smaller. It's more concentrated in urban areas. So it will help with providers, but you'll probably still have issues in rural areas. There's a 15% increase for OB and gynecological services. You see those rates are currently about 86% of Medicare. There's a 30% rate increase of about $6.2 million for vision services for children, and then 3.7 million is for psychiatric residential treatment facilities. So if you remember, we had just kind of changed their rates here recently. What this does is it adds a 3-year rebasing cycle that every 3 years their rates get updated closer to their cost and provides an annual inflation update to them. So you can see that the total Medicaid provider rates are almost $340 million over the biennium. Moving to slide 6, I'll talk a little about the DD waiver rates. This chart shows you which services they increase. So that's one of the, it's not a, even though the Department of Behavioral Health did a rebase of all their rates, they contracted with, you might hear, if you hear it, the Burns and Associates is their contractor they have on retainer who does the rates for them. They rebased all of them, but they limited their increase to these services, partly probably to keep the cost down, but their justification is really to focus on those services that they wanted to encourage that DOJ would prefer. Of course, so what it excludes is a variety of other services, so any group home larger than 4 beds, which, I think the issue really is that regardless of what setting you're trying to entice, they're all providers, they're all providing services to Virginians, and their costs have all gone up. And so I don't think it's as simple as we can just exclude them, because what happens if they can't survive and they close. We still have to have a place for those individuals that they're caring for to go to. So, and these providers, just like a lot of providers in health care, basically they have a lot of issues. So you can see this doesn't list all the services that are excluded, but it lists some of them. The other thing to note too is the rate increase doesn't, if as you all know, that in the waivers that people get CIS scores, and it determines so they have 4 tiers, which is kind of their level of need. And they actually set provider rates by those tiers. And so for group homes and sponsored residential, some of those services, they didn't really show the rate increase by tier. They just kind of averaged across the 4. And that's just one thing to think about is if you have rate proposals that's actually tied to each tier, then maybe you want to look at whether or not you would want to maintain that or not. So, and you've probably heard from advocates and stuff, some of their concerns about the DD waiver rate. So it is a lot of money. I think everybody's grateful for that. It's just now, I think, kind of getting it right to make sure that that investment in providers can help sustain them during what's a very tough time. So the next slide, 7, this is just like I mentioned, kind of physician rates. Just wanted to show you, this is like the percentage of Medicare for fiscal year 21. So like I said, there's a rate increase for OB. That's currently at about 87% of Medicare. You can see it ranges greatly. There's also the increase for primary care services, which you can see is roughly about 70% of Medicare, which is probably why they included that increase as well. But psychiatric services is the only one that's closer to the Medicare rate, because we've actually increased those in recent years, actually 2 years in a row. But you can see there's a kind of a wide range there. So moving to slide 8. So you can see, of course, we've talked about the forecast before, not just for Medicaid, but the Children's Health Insurance Program. Those are, even the children's programs are fairly normal growth rates for, modest growth rates for this next biennium. There's 1,200 DD waiver slots, 600 per year in the introduced budget. I know that's something that you all have talked a lot about in recent years. It's one of those things where, the state does have more resources than it would typically have in a biennial budget. But the issue, of course, again, is the providers. The issue right now is even the slots authorized for the current year haven't even been released by the department. For different reasons, but there are also even some slots that I think from the previous year that might be unused. And when you have the lack of providers, then it makes it harder to fill them. But but something to just keep on your radar. Um, As you can see, there's a variety of the other things. There aren't that many policy changes in the Medicaid, which is probably a good thing because there have been so many in recent years. It gives DMAS an opportunity to kind of make sure that it implements them and implements them well. But you can see that there's the elimination of all copays for Medicaid and FAMOS. They're kind of haphazard anyway, that some managed care does, like in Medicaid, managed care doesn't do them, but fee-for-service does them and stuff like that. During the public health emergency, they've been suspended per federal rules anyway. So this just kind of continues that. And of course, copays in Medicaid and FAMOS are very, very small and not enforceable upon the patient. The only things I'd note, like in some of the DMAS administrative stuff, there's like 100,000 to study like the human milk bank donation. That's something to look at. I'm not sure if we need to study it, but there's some small things like that we're looking at. There's also 6 positions.
It just got through the mandated benefit level, it's called that.
Right. And I think this is probably us. Right. That's one of the questions. I don't know if this is more from the Medicaid perspective but it's something that we'll look at. And then there's 6 positions for financial oversight and provider reimbursement at DMAS, so that should help kind of boost their financial oversight capabilities. Slight increase in the healthcare fund, just increased tobacco taxes. Also, thing to note too is that for Children's Hospital, the King's Daughters, there's language in the introduced budget that this is not unusual, that when we have to do repayments. So there was a big case related to disproportionate share hospital payments related to children's hospitals. It was a national case, but the children's hospital is lost, and so now we have to repay money. It's actually almost $40 million. But what this language does is it forgives them of repaying the state share back to us. That's pretty normal with things like this, that especially when the state thought that their policy was correct. We don't make the provider repay us, but they still have to repay the federal government, CHKD does, which would be almost $20 million. So they've had different budget amendments to try to help offset kind of some of those costs as well, but just to highlight that for you all. On slide 9, community behavioral health, you can see it's almost $130 million. Again, with all the investments in recent years, this continues to sustain those investments. The first one, over $50 million, fully funds STEP Virginia. So kind of the last 3 services listed there. It also adds additional funding for infrastructure needs and more support for CSBs for implementation of STEP Virginia. You can see permanent supportive housing, $34 million is added. So this supports an additional, it's actually 1,250 individuals, adults, and then 75 pregnant women, because there's a separate pot for that. But I'll just note, too, that if you recall, it wasn't that many years ago where we did almost nothing in permanent supportive housing. This actually brings in fiscal year 24 the total amount dedicated to it to almost 55 million general fund to support it. So that's supporting well over 3,000 people with serious mental illness.
Mr. Chairman, I don't understand why there's only one position for that many
Mr. Chairman, Madam Chair, this is, I'm trying to think how many they have supporting it now. This is really just to administer it. They really just distribute the money to different providers and CSBs that provide the services. So it's just an additional administrative person at the department. It's not
finding the housing.
No. That's actually up to the people that they give the grants to.
Okay.
Yeah.
And they provide the oversight as far as follow-up, as far as the well-being of the individuals in those types of departments?
They might to a degree. I'd have to. Then you can see there's $24 million to continue with crisis system transformation. This is kind of 2 pots. It's converting centers to receiving centers. That's part of it, and it's also mobile crisis. The first year number of $2 million looks low, but there's $20 million in ARPA funds in the back, so it's actually $22 million per year. Then you can see an additional $3 million per year for implementation of Marcus Alert. So this is the next phase for 5 more localities for Marcus Alert. There's $5.8 million to expand the Virginia Mental Health Access Program. So this is the program that you all fully funded just in the last couple of years that really gives support to in pediatrician's office. Now this proposal kind of expands it to other settings like urgent care. Then you see $5 million in fiscal year 24 to continue substance use disorder programs. So this is basically to continue what was funded from ARPA. There was already $5 million, and so this kind of puts it in the base going forward. And then there's the dementia pilot program. This is that one down in Mountain Empire to kind of take dementia patients and keep them from the state hospitals. So that sustains it. It's funded now from ARPA funds. So this kind of continues that pilot in fiscal year 24. And you can also see other things for mental health dockets and boosting outpatient restoration services at the CSBs. So slide 10 deals with behavioral health facilities. Of course, the big thing here is, a lot of the focus in recent years, of course, has been the community. The idea, I think, one day that, maybe the state doesn't need to have as many hospitals as it does. But of course, COVID and the TDO, those kind of together have just compounded on the state hospitals. And so it does require significant investments to kind of maintain them. So you can see fiscal year 23, the direct care staff compensation. So this is increasing them to 75% of the market median, which right now they're roughly at about 10. So it's a dramatic increase in compensation for direct care staff. The 23 amount is funded from ARPA. And then you can see 80 million in the second year is the ongoing support for that. You could also see 5.1 million per year as a pilot. So this is at Central State and Southern Mental Health Institute. So right now, discharge planning and therapeutic intervention services are only provided Monday through Friday. And so this is the idea that at these two facilities, they'll provide them on the weekend as well, under the idea that that means that you could probably discharge folks quicker, as well as so that you can relieve some of the pressure. So it's a pilot to start there. You can also see the overtime pharmacy costs. There are benefit positions at state hospitals, and those are positions where basically they help people to access other benefits as they leave the hospital, whether it's VA or Medicare, a whole host of government benefits. And then, of course, there's expansion of telehealth at state hospitals, and that the first year amount is funded from ARPA. So other items, slide 11 for DBHCS, $2.2 million per year for grants for recovery residences. I believe the ARPA funding level is about $10 million, but this would put general fund toward it. There's about $3.8 million over the biennium for the state rental assistance program. So this continues that program with rental subsidies. $3.8 million fully funds the alternative transportation project. So this is now that it's functioning statewide. This is the level of funding that they need for the contract to basically make sure it operates 24/7 statewide. And then the next one kind of ties to it. The introduced budget included some language to look at alternate custody options for TDOs. So this is the idea of a sitter. A lot of people who are sitting in the state or in the ER that are waiting. It's typically for the bed to open up in the state hospital or private hospital. And so they sit there, and of course you all hear from law enforcement that it taxes their resources. So the introduced budget proposed looking at it the first year and then $3.4 million the second year to fund what the recommendations are. I think based upon the bills that are before you all now, I think more of the idea is the action is probably going to happen this year and not wait because it's too pressing. So that'll be something to discuss, and we'll see how those bills progress to the General Assembly. You can see the supervision of the sexually violent predators. And this gets to something, too, that, the facility itself is basically stable. It really isn't growing. They're pretty much conditionally releasing them and then supervising them in the community. So the expansion of the facility hasn't been fully utilized yet, just because and part of it, I think, was COVID, too. They didn't want to keep them all in the facility, so they, I think, tried to, if they could, to conditionally release them.
What exactly do you mean by the supervision of sexually violent predators? This is while they're specialized parole officers?
They're DOC probation and parole officers. So DBHCS pays DOC to supervise them when they come out. So this is all related to the payments for that, which can occur in two places. Sometimes people leave DOC and they're conditionally released at that point and never go to VCBR, or they could go to VCBR and then they reach the point where they could be conditionally released. In either case, DBHCS is paying to.
It's a probation role.
Yep,
And
they're
they're
DOC.
trained, as I remember.
I would imagine so, yes, because the rules surrounding the supervision of SVP would be different than a normal probationer.
Probably need to look at most closely at the women for a while, because they one point, nobody was ever getting out of there.
Right.
The concept was that they would still want to plan the expansion.
Right. And you can see there's a pilot project to cover the licensure supervisory hours for counselors. So this is the idea you might have heard, the Virginia Healthcare Foundation, a pilot. It's basically for some of these counselors that they actually have to pay for supervisory hours to ultimately get there. And so this is the idea of a pilot for the state to actually pay for it to try to get more people in those professions, kind of a health workforce thing. Most of the smaller things you can see looking down to try to deal with a variety of things. There's also, we talked about earlier when VDH presented, there's $1 million per year for underage marijuana use and prevention at DBHDS. So Senator Eben asked the question about coordination. It's because at the health department, they deal with adult education. At DBHDS, this money is actually intended to, most of it, I think, go to the Virginia Foundation for Healthy Youth to deal with underage possession of marijuana. The last thing I just noted on this slide is there's $1 million the first year to study the state behavioral health system, and then in central accounts there's $100 million reserved the second year to implement its recommendations, which is not something that we would typically anybody would ever have the money to just reserve. So that's kind of unusual. I think the question for you all is, does the system need to be studied, again, or if it does, what would it be focused? How would you do it? I mean, exactly what do we need to look at? So
I'm thinking we have the mechanism to consider these commissions, which has now become behavioral health commission. really
It's
the
permanent.
framework
Why
Right.
can't it do the work?
for it.
Right.
It should.
well, and that could be part of your discussion is you could, maybe you would actually give some more money if there's some things that you want them to look at and if they needed a consultant to help them. But
And one of the problems that we know, I think we've made some good policies, we just don't pay people enough to set the system up.
And,
Yeah.
Mr. Chair, the reality is, some of the problems we have at the hospitals have gotten the headlines. But what I'm hearing in the field is that the pay issue is very real in the CSBs too. So we have big things to address.
so in slide 12, you'll see, I won't go into great detail. These are more administrative items in DBHGS. I mean, the first one's discharge assistance, which isn't all administrative, but there's money there to kind of look at rates for discharge assistance, as well as to have a tracking system so that they can better track it. Right now, I think they probably do it just through spreadsheets, and I think the idea is they would have their, but you can see IT systems, electronic health records, upgrading that, and a variety of other positions to help them administer the different programs. So moving to social services. Sure.
On the electronic health record upgrades, is this all being coordinated so whatever is going on in DBHDS is compatible with whatever is going on in the health department and whatever is going on in social services and so on? To each other?
Yeah, Mr. Chairman, Madam Chair, so to much better so than it used to be. You may recall a few years ago when DOC, DBHDS was kind of upgrading it to a new system. They already had one, not at every facility, and then VDH wanted money, and we kind of said, no, we want this all to be, make sure there's interoperability and things like that. And so we created a work group in the Secretary's office that has met for several years. And I can tell you that, yes, on that work group, myself, Susan Masters on it as well, and we have done everything we can to get these agencies to coordinate. And they're doing much better than they used to. So that was kind of the point. And so, yeah, I think they're in a better place than. And that work group continues in this introduced budget. So, I'll probably be doing it for years. So for social services, you can see the largest one at the top, 40.6 million. That's a little bit higher than it typically would, is the foster care and adoption subsidy payments that are higher. That also includes the cost of living increase. So per the Appropriation Act, the year following a state employee raise, foster care and adoption assistance payments are increased by the same percentage. So you would see this in future years too. If the 5% takes effect this year, next year, then each year you're going to see an ongoing increase in those costs. Just to note, the Child Support Information System, there's 3 major systems in DSS that they're proposing to replace. So the Child Support Information, it can pay for itself because child support is funded by non-general funds, but you can see almost $40 million to replace that system. The third line is the supplanting the TANF-funded discretionary program. So this gets to what you saw in the health department, which is for resource mothers. So when we go through budget stuff, we always talk about the TANF spreadsheet and the structural balance in TANF and that sort of thing. Well, now it seems like they feel like we're reaching that point where it's structurally unbalanced. So what you'll see is they've supplanted about $8.5 million per year of things funded with TANF and switched it to general fund. So to kind of reduce the burden on TANF to kind of sustain it ongoing. And they put language in there to continue to look at this. It's something that I'm looking at to see because right. But yes, it is, we're definitely spending more, and I think part of it is, you all know that in recent years, we've increased the TANF standards of assistance. The idea is to kind of focus on, well, let's kind of increase support for the mandatory parts of TANF, because all these other programs are discretionary, and so that has gone up. But we'll have to just look at that structural balance. So the program, nothing happens to the programs, they're just being switched to general fund. But we'll look at that going through the budget. The next one, replacing the Virginia Case Management System. This is the one that basically handles Medicaid, eligibility for Medicaid, and basically other public benefit programs at DSS. That's another major system they want to replace. And then there's the Child Welfare System, which is probably the highest priority, about $10.6 million. That needs to be replaced. It's really, they've been working on that for years to replace it. There's also, you can see $4 million per year for the Office of New Americans. It's called the Public Benefit Navigator Pilot Program, which doesn't, it's really the idea, and it may end up being focused a lot on like the Afghan refugees as well. But the idea of really helping with refugees is that they really need assistance with housing, finding housing, and then legal assistance as well. Because especially with the Afghan refugees, there's potentially a significant number of asylum cases that would hit the federal courts, and of course, these are individuals that may need help with the legal assistance to represent their case. And so a lot of this funding could support those activities. There's the mandated reinvestment of child welfare. That happens every time. It's like it's the savings that we get, we have to reinvest it. So it's not like we actually save anything. We can just put it into additional child welfare activities. You can see the Section Domestic Violence Fund. Actually, I'm not sure if it's 1.7. That might actually be a mistake on my part. I thought it was 650. But anyway, I think with the so I think there's additional amount in the introduced budget, and there's some other member amendments that you'll see when we talk about that for them as well. I know y'all didn't go into it in great detail, like the language that's kind of in the health department. This is the issue that I think you all will have to discuss in subcommittee as well. If you remember back to last session, the issue was that there were some federal funds that basically the health department indicated to 6 of those organizations that they were going to use the money for a different purpose, and they kind of felt like that was kind of sudden. And so you all put language in directing VDH to continue to pay them the federal funds, and if they couldn't, then to basically backfill it with the prevention fund, which was new. And so I can just tell you that it's been quite the adventure over the past year. I don't think that, from my perspective, it seems like the federal funds could still be used to support those 6 organizations, but VDH has a different interpretation, and I don't know if they've paid it out yet. But it was just in December. They were basically the prevention fund. They had asked for information about paying it out. I don't know if they've done it yet, so they probably haven't.
We put in the budget that they were to do that.
Yes, we did.
So what option do they have?
Right, right. So,
I
it's,
just don't get it. It's very, very.
yeah, it's been an interesting issue because I'm not really sure what the, what the rationale is to not do it because it doesn't do any harm to anything. What you all were trying to do is to sustain those 6 organizations until the next year when you all could take a look at it again and then decide what to do. And unfortunately, at the end of the day, I think those organizations, of course, without the money, had to cut back on staff and things like that, which was just the wrong time because the demand for those services was increased. So,
I'm just, aside from the merits, which we obviously have decided deserve being in the budget, I am extremely angry that they're not following what we told them to do.
mhm.
And if anybody out there is listening, I'm
Yes.
extremely angry about that.
And Mr. Chair, Madam Chair, is like I have stressed that that this is an important issue, and we're really talking about federal funds. I'm not really sure what the issue was. So, but it's something that you all will continue to take a look at. Most of the rest of these things are more administrative in nature. So I think we'll go into the health department. Like I said, you just heard from the acting commissioner of health. I'll just highlight the first one. I think Senator Hanger, you asked about the e-referral system. So just to give you more background. So that was originally funded, 10 million was put in for ARPA funds. Now, to be honest with you, it was some very vague language, so we didn't actually know what they were going to use it for exactly. So what they did is they contracted with Unite Us, which they mentioned, to create this e-referral system. They do have a major competitor who used to be named Aunt Bertha, if you've heard that name. Their new name is called Find Help. So the managed care companies in Virginia, some of them are already contracted with this company, Find Help, because they like to provide referral services to people that they serve as well. But what the introduced budget does is it puts in language that says that they're supposed to RFP it. Because when they originally did it, they did an emergency kind of procurement, which doesn't go through the formal RFP process. So you didn't really have competition. But the way the intended language says is that now you would actually have competition. But it is kind of neat, if you haven't kind of seen it, that its whole purpose is, you kind of almost, to be honest with you, you almost have to wonder why the state didn't already do this itself. But it basically provides access to all the community resources that a person could use, from food to housing to whatever. And it's just like, I've seen the Find Help website, and actually that one you can access at some level that's for free. And it's pretty neat. You just put your zip code in, and it just tells you everything you need to know about these organizations. And it's a very comprehensive thing. And this part of what the state's doing is a little bit more sophisticated, because what they do actually behind the scenes is they actually track the referrals. So if you're at a nonprofit, that nonprofit participates in their system, they'll note that we advise this person to check out these services, and they can send that referral to them. And when they do it, it keeps track of it to make sure that they're following through. It's not one of those things where typically an organization says, "Oh yeah, we think you should get this service and you should go talk to these folks." Well, once they do that, they never know what happens. But this system actually tracks that, so that you actually know that people are following up or being followed up with to access services that they might need. So it is actually pretty neat. Anything else? Let me see the note here. I talked about the TNF for resource mothers. Continue on page 15. If there's anything to note. It's a lot of smaller things, but I think since Dr. Green already covered a lot of that. So then I'll jump to slide 16. So the other HHR agencies. So aging and rehabilitative services actually got more money than they would typically get, and this is really related to the public guardianship slots, about 300 more. If you remember that JLARC did a whole study of public guardianship, and I think they recommend a little bit more than this, but that was in the introduced budget, so that was a pretty sizable increase. There's also additional money for the VICAP, which is the Virginia Insurance Counseling Assistance Program. So this is where typically an elderly person could call and get help with Medicare, whether it's Medigap policies or other things about Medicare, to give them assistance. Additional funds, $600,000 per year for Adult Protective Services regional staff. There's some money to address procurement deficiencies. This is to hire 3 additional people. Apparently, General Services noted some issues in their procurement there, so there was a recommendation for them to have positions to do that. There's money for the senior legal helpline to continue that, and an additional small amount of money for the Jewish Social Services Agency, which is a pass-through in the department, and then some money to support the Adult Services Case Management System. In blind and vision impaired, you can see a little bit of money, $800,000 a year for workforce services for blind and vision impaired. This is the vocational rehabilitation program at DBVI. About $300,000 a year to enhance campus security. Their campus is off of Azalea Road up in North Richmond. And then $200,000 a year to fund 2 education coordinators for students. And then I would just note the other smaller ones, in 17, Children's Services Act, just a few things related to IT security, IT staffing, and some training funds. And deaf and hard of hearing, the creation of a deaf mentor program. So there's a little bit of money in for that. And then the only item for the Secretary of Health and Human Resources was language to continue the primary care task force. This was something started about 2 years ago that Governor had started. And so they're proposing language to kind of continue that. That might be one that we have to kind of work out with, there's, in the Health Department, for the first time, there's money to fund the Healthcare Workforce Development Authority. That money also encompasses money to do a study of primary care. So we'll probably have to make sure that those are kind of coordinated. So slide 18, this is just to note the ARPA allocation. So if you remember, there's still some ARPA funds left. Almost $250 million was given to HHR. You can just see a little bit. There was some to social services, about $6 million over 2 years for their. This is more their network infrastructure, just like Dr. Green, I think, talked about like the local health departments and their ability to like communicate through broadband. Well, the departments of social services have some of the same issues, so this helps with that. And you can see in the Department of Health money for their systems modernizations, which includes electronic health records, continuing support for well and septic systems, $25 million per year for drinking water. So this is in addition to what you all had already allocated from ARPA funds for drinking water. Then some additional funds for substance use disorder and suicide prevention, and support $5 million to support free clinics, all into the health department. Most of the money you can see in DBHS is related to the direct care staff salary, about $83.7 million. But there's also some money for telehealth and PPE, continuing substance use disorder services funded at DBHS of $5 million, and the dementia pilot program. This is the first year of that, and then the fiscal year 24 is where they come back and they add the general fund to keep it going. And then lastly, DMAS has a little bit of money to address kind of operational backlogs. And the only other thing that I would note is on Friday, the governor sent down his executive amendments. He only had one for HHR, which, yeah, it's kind of surprising, which Dr. Green kind of references. It's $1.8 million per year to fix the issue with the Office of Drinking Water.
Oh, okay.
Yeah. But that was it for HHR. And, well, I mean, yes, to basically fully fund their operations so they can, just like back in December where they avoided the 14 layoffs to do that. So with that, Mr. Chairman, that concludes my presentation unless there are any questions.
Okay. Questions, Tim? Okay. Thank you, Mike. Appreciate all the details.